Good morning, everyone. I am Ara Metjian. I am going to give the next talk, which is on the the long-term complications of TTP. And since I'm the one keeping everyone from lunch, you got to be nice to me. So,
There's no good news.
I'm sorry?
There's no good news on the side.
Well, so just here's my disclosures, standard stuff. Technically we're going to talk about the use of rituximab is technically off-label, even though it's considered standard of care, so this is just to get everything out of the way. A little bit on me. I'm an adult benign hematologist. I used to be here at Duke and got recruited to the University of Colorado. I've got a focus on thrombosis and hemostasis, but mostly TTP. And so this talk is going to kind of wind around a little bit, and it's basically a recant the talk I usually give colleagues, fellows, residents, interns, students. Instead, obviously it's going to be geared towards patients. So we're going to go around a little bit, but it's ultimately part of this is just in essence, this is how I think, this is what what we're going through, and how your interactions with maybe someone who treats TTP is thinking, the reason we're saying things, the reason we're recommending, how we might think, speak, act, kind of go around. It's gonna, in a meeting like this, we talk about what else can we do to improve, right? What are the areas that I think are, the broad category where we need to improve? So, for instance, the pathogenesis of TTP, right? We still don't know what makes this happen. Of all the enzymes, of all the things in the human body, why the heck that it's ADAMTS13 and not anything else, we don't have a very good answer for that. Well, we know how to diagnose this, yes, it's a deficiency in ADAMTS13, but how can we get more rapid testing? None of this nonsense of it takes a week to get back from certain centers, or what could we do to make it more reliable and more widely available? Do we still need plasmapheresis, right? And this is what the Mayari trial is going to try to answer. The question is, will capivasertib work just as well, if not better, and be safer than the use of plasmapheresis? So in order to answer these questions, this is why we need patient participation in clinical trials. Some of the conversations that we've had is, how do we get rid of this inhibitor? It's great when prednisone works, it's great when prednisone or rituximab works. What happens when that doesn't work? And after that, we really don't know. And this is the next step. And of course, what we're really here to talk about is what happens afterwards. What are the problems? What are the issues? What are the areas of improvement for survivorship? And so we can think of this, let me rephrase this, how I think of this in two distinct ways. The acute process, right? What are the problems that happen during the acute process, during the hospitalization? These are the things that I think about. Issues related to stroke, because we know about a good 8 to 10% of TTP patients will have a stroke in front of us in the hospital. Okay? We know that there's heart attacks. As a thrombotic microangiopathy, we've got platelets, blood factors, clogging of arteries, heart attacks. And we know that cardiac involvement, heart damage, this is one of the more common causes of death in TTP. Issues that are just related to the procedure itself, putting in that central line. For those institutions that can't do peripheral IV placement for plasma exchange, we have to put this guard-in hose in someone's neck, under their collarbone, or in their groin. And there are issues that are related to this, like getting that line getting infection, when the lung drops, so to speak, or if there's infections that are related to this. There's, continuing on with the complications that are related to the treatment of plasma exchange, right? We know that by giving plasma, there's issues with this thing called citrate that we talked about, in which that can cause low levels of calcium. By giving liters upon liters of someone else's plasma to you, that can cause an anaphylactic reaction. Who knows, they had a peanut, they were having an allergic reaction, and now we're flooding the patient with all this plasma. And to be complete, we worry about viral transmission. It is rather uncommon. By that I mean I'm unaware of it ever happening. But we're giving someone else's plasma. Sometimes we're giving someone else's blood. Sometimes we're giving someone else's platelets. And what if they have the flu or COVID or Hep B, Hep C, HIV. I mean, it's remarkably rare. It hasn't happened as far as I know, but it's something that we think about as a risk of doing these procedures. Of course, you know, there's the risks that are associated with immune suppression, which we've already talked about. What's the consequences of steroids for rituximab, or when that doesn't work, the long-term effects of the immune suppression that we need to give. And of course, we think capivasertib is sort of the standard of care when it comes to the treatment of TTP, but we realize by its mechanism of action that it's going to increase the risk for bleeding symptoms, right? So we know that 65% of patients that were treated versus 48% had high rates of what we call mucocutaneous bleeding, nosebleeds, gum bleedings, increased bruising on the skin as a result of having this. So that's what we worry about, we think about, we try to deal while we have our mitts on the patient in the hospital. But, you know, all of this is to get that person out of the hospital. So what happens when that patient goes home? Where are the areas of improvement that we can think about? Well, this has been a long journey. You know, this has been over 20 years that in Oklahoma, they set up a survivors of TTP support group. And what they said, and I'm going to read this, I'll quote this, most former patients describe persistent problems with cognitive ability and endurance. Our former patients as a group have significantly impaired health-related quality of life. And a follow-up, he knows that many patients feel as that they are not as capable, mentally or physically, as they were before their acute episode of TTP. I'm not going to ask for a show of hands, but I see a lot of nodding. Right? By this time, this has almost been a century that we've known about TTP. But now we have the luxury of people being able to walk out of the hospital and go home. So now not that we're victims of our success, but we're seeing complications, developments that we never would have thought of 50 years before. So this has just led to unraveling. So if patients are saying, I can't think straight, I don't remember well, I don't have the get up and go that I used to, what else is it that we've missed? What else is it that's out there when someone has survived TTP? Well, the heart issues, cardiovascular. What we've realized, you know, looking at the Oklahoma registry, that there's higher episodes of high blood pressure that seems to occur afterwards. Looking at data from registries from Hopkins and the Ohio State University, right? Looking at you back there. You know, these things called major adverse cardiovascular events, things like heart attacks, strokes, and hospitalizations for heart failure. These seem to be complications that we're seeing in the survivors of TTP. And the need for other things like catheterization or bypass procedures. Along those lines, oops, that's wrong. We know that this occurs 1 to 2 decades before that of the general population, right? Obviously, in a Western society, we see lots of heart disease, but this is occurring sooner, faster in our survivors of TTP patients. And at the very least, what we can tease out is that if our TTP survivors are of older age, they have other comorbidities like diabetes or high blood pressure, or if they're African or other, what we call versus non-white race, it's associated with a higher risk of these major adverse cardiovascular events. And as a result, death from cardiovascular causes, heart attacks, strokes, failure, is just as much as someone who has relapsed from TTP, which we don't classically think that is the major cause of death. Other things, this is a big thing, depression and post-traumatic stress disorder. There's higher rates of depression in patients with TTP, right? Almost 5 times that of the general population. And this isn't just related to just, hey, how many times I've been in a hospital, what if I have test 13 level? We also know that there's a high rate of PTSD. And this is a disorder that occurs in people who've either seen something traumatic or they've been through something traumatic. Some symptoms, if this is familiar to anyone, when you have intrusive thoughts where you can't stop thinking about what happened. Nightmares, flashbacks, hyperarousal, so high blood pressure, racing heart, sweating, or symptoms of avoidance where I know I should go see the doctor, but I don't want to. Every time I see the hospital, I want to vomit. Really?
It's real.
Yeah.
It's a smell. Right, all of those, right. Well, it's like, yeah, if it's the smell of smoke, it would smell of soap. Right? I mean, yeah, it's going to be that. And so these, we know, are what our patients now are telling us. And we would have never thought of this 20 years ago because we never had the luxury of seeing someone in the clinic. So we know that this occurs, right? And so what the French have shown is that almost half of their patients have these symptoms of PTSD. And it doesn't seem related. It can occur a week after you get out of the hospital, a year after, 5 years, 10 years after that this comes back. And if this is there, it increases the risk of depression, weight gain, and worse quality of life. Not to mention their symptoms of avoidance, right? And I think, you know, all the docs here say, like, the time to try to call someone and say, hey, I need you to come in, get your ATTP 13, your platelets checked. But that person, that fear of going back to the hospital, that gut churning, I want to puke if I go back there, that's worse than saying I'd much, you know, not that you want to go back through TTP again, but it's just they'd much rather avoid it. So this stands as a barrier to the care of patients. Along the neurologic stuff, we've talked a lot about stroke. We know that stroke can occur in the hospital, in that acute setting, invariably from that thrombotic microangiopathy that's occurring in the small blood vessels. However, we know this happens even in remission, right? Specifically, looking at like data from the Hopkins registry, we know that 13% of patients had a stroke even while in remission. That was unrelated to their episode of TTP. And that we can relate this to lower levels of ATTP 13. Not low enough where we expect someone to have a thrombotic microangiopathy, but not within the normal range. Continued follow-up from the Hopkins registry. And this is a big one that recently got published. The presence of what we call silent cerebral infarctions. We see this in related disease that hematologists take care of, sickle cell disease. And this is where we see what looks like MRI evidence of strokes, but without any of the neurologic manifestations. There hasn't been an acute change where all of a sudden there's numbness, weakness, difficulty speaking, walking, talking. But what looks like on MRI, the signs of strokes. And it's noted in about half of patients who were in remission. And it is associated. Yes?
Good question. Could that be tied with maybe some of the cognitive impairments, like having trouble recalling words, or feeling like you want to say one word in your head, but then what comes out is like a completely unrelated word?
Yes. Yeah.
Would that be a cause of that? With like, there's no real neurological symptom, but maybe you're having some kind of a side effect from that?
We are still, this is literally off the presses.
Okay.
But it is, if you poll Dr. Catalan, are we surprised that this happens? No. We know, I mean, at the very least in MRI is what we can see via a radiographic or radiologic study. But what is going on at that level where your thoughts stop? Or you switch a word? Can we see to that level? No. This is the things that we're seeing, just by MRI. But it's what we've seen, it's what our patients have told us. I mean, time and time again, like, doc, one of my patients, this is why I bring my sister. I know what you're saying, it makes sense, but on the drive home, it's just, I'm gonna forget it. Yeah. And at the very least, this is what we're able to see sort of macrovascularly, right? Good question. And so, what does this mean, right? And so, so where to go for this is that this has now led to the authors saying, like, look, there should be aggressive screening and management of risk factors that can lead to stroke. We have TTP, we shouldn't have anything else on this. So I've just rattled off all these things about line infections, plasma, strokes, heart attacks, depression, PTSD, silent cerebral infarctions. The intent of this was not to make this into sort of to be the Debbie Downer, but this is what your doctors are thinking, or your TTP doctors are thinking. This is what's going through our heads. This is what motivates us to push our patients, to do the regular testing, to recommend other things which we're going to get to, as well as for the clinical trials and why we are here. And part of this is there are no international guidelines, national guidelines. Like, what do we do? If you're asking us, well then, gee, doc, what do I do to prevent stroke, heart attack? I can't give you a randomized prospective double-blind clinical trial on how we prevent cerebral infarction. We don't have that. What we have is my 2 cents, which I think are pretty damn good, so I'm going to give it to you, right? And here's how I approach sort of TTP and how I think about this in terms of, and I'm going to get to some points, so bear with me. So when I'm seeing someone with TTP, these are what I consider like sort of my 4 basic tenets of how I care for someone with TTP. 1, the rapid and acknowledgement and treatment of relapses. So if someone I think is going to have a relapse of TTP, and I'm worried about this is why there's the routine monitoring of CBCs and ITTS-13s. This is why for the one person who is seen as a patient in this room, if I'm being a gigantic pain in the neck of someone, it's to prevent what's happening. This is why there's the CBC, right? In the beginning, it's the weekly CBCs, the weekly ITTS-13s. And as we see that normalize, as we see that come up, then we start to disconnect the patient from monitoring and from the hospital. Because what we want to do is avoid another relapse. And when we see that someone's platelet count has dropped from 250, now it's 153. When we're like, we need you to come back in another week to make sure this is not a fluke, or to see if it is. And if it is only 120, no, I need you to get into the hospital, right? We need to start doing this. It's not because I've got country club dues that are due. We know, we don't want to be at the point where we say, frick, we should have done this sooner. I'm trying, Claire, I'm trying. Prevention of relapses. This is the next step, right? I think we've pretty much gotten a good handle on how to rapidly diagnose and treat TTP. Well, then how do we prevent this from happening again? And again, this is regular monitoring of ITTS-13 levels. And the question that was asked about preemptive rituximab for ITTS-13 testing, what the French showed is that when they monitored their TTP patients and they started seeing that drop in ITTS-13, well, instead of waiting until that drop in ITTS-13 was also correlated with a platelet count of 10 and schistocytes and bleeding symptoms, well, why don't we just nip that in the bud right away? And that's the
What do we do when our insurance doesn't want to cover that? The French don't need to worry about that.
Yeah, so that is of course, that's the reason why I went to medical school, was to fight insurance companies, right? That's what I mean. But it has to be, this is easy for me to say because it fits in with my personality to be aggressive and to fight and to be obnoxious, but we do this, and that's, it's like at what point in time do you not take no for an answer? And there's been the letters, the appeals, the reappeals, then you finally call someone, and then you say, look, when this person relapses, they're in the hospital, that cost is going to be quadruple, 10 times more than what you would have done if you just kept this patient out of the hospital, and we wouldn't have to do this. It is, and because half the time, it's not a defense, but the person who's rejecting, they're going down a black and white checklist, rituximab. Is this lymphoma? Well, no. Well, then why are they getting rituximab? Because, to be precise, it's not FDA approved, right? I mean, if we went very binary, very black and white, I can't recommend it. I do. It's not FDA approved. But we do it because we have all this data that it works, right? So yeah, it's just not taking no for an answer. Was there another question?
Oh, sorry. So how long would it take in order to get that FDA approved if we have all this data in order to feed the FDA?
Summer child. As Nancy right here, bless your heart. I would love to do it. I would love to do it. Because there's a lot that you get, from the doctor, and there's a lot that you get, there's more that you get out of clinical trials. There's all this data, all these lives that you get out. But it would, I mean, it's been tried, and it has not gone well, and we sort of just worked our way into it. I would say that, pragmatically, part of the biggest barrier would be from the companies themselves. They've got no incentive to plunk down $250, $500 million for a drug that's already being used. They have zero incentive to do that. Any other questions? All right. So preemptive rituximab, when we see that ADAM-TS13 level is dropping. Okay. Then things we think about is how do we treat complications that are directly related to TTP? Things like catheter-associated thrombosis, right? We're putting a garden hose in someone. What happens when someone gets a blood clot? What happens when we make their life miserable by putting a patient on high-dose steroids, weight gain, high blood pressure, high sugars?
Roid rage.
Move further back, buddy.
I'm not on it right now. You're safe.
We'll see you live there. All right. And of course, what we worry about, have there been viral infections from plasma, right? Things that are the direct complications of what we've done. But what we're getting at now is that, the treatment related to TTP, and it's recommended that we regularly screen our patients, annually for cognitive repression and depression annually. I'll be the first one to admit, I don't know how to do this. I just ask, how are you feeling? How are you thinking? I don't do the battery of tests, but for my patients, I do send for neuropsychiatric testing, right? What are the areas of people who know how to do this a lot better than I do? But at least I put it out there. And I encourage people to say to their doctor, I can't think, I'm having trouble concentrating, my memory's not as good, right? I'm worried if I'm going to work that I'm going to foul up and not do what I need to do. I'm not operating at the level that I was before all this happened. There's nothing to be gained by keeping that silent. And so preventing, and then this is where we're at the next part, preventing the diseases that are associated with aging. Now that we expect our TTP patients to get out of the hospital, well, what's the point of going through all of this? What's the point of surviving all this if someone has a colon cancer that's missed? They don't get their flu shot and they die from the flu or COVID, right? Because since we're expecting people to live longer, there's all the other things that come on. And if there's all these other comorbidities that come with it, cerebrovascular, cardiovascular, all those other things that can impact that, if someone is smoking, obese, high blood pressure, high cholesterol, diabetes, those things need to get checked. Those things need to be treated. And so someone like me, I can do this, but that's what I'm usually pushing my patients. Look, we need to work with your primary care physician in order to get these things taken care of. Because what's the point of surviving TTP if you're now on oxygen because of your COPD? Or you've lost your leg because of the complications related to diabetes. Okay. On that note, nice. Okay, with time left, if there's any questions. Yes, ma'am, in the back.
Do you have like a list or a way to access your, like the studies and literature that you have that is, like everything that you just presented is my constant fight with my doctors.
Okay.
To recognize the chronic symptoms that I have and not be dismissed. And I feel like it's just a losing battle. So I feel like if maybe I had like studies or literature that I could be like, here.
Yes, we could fill this room. Everything that's on there you can print out. Yes, sir, I'll just jump over the line. If you need another doctor, go get another doctor. If you need another, for me, if a patient is not, I regularly encourage second opinions. One, I'm pretty damn confident I'm giving the best advice, and I can say, I told you so. But from a doctor,
I'm going to give them your side job.
you can give them my name and number. I'm happy. Anyone here, as part of the USTMA, we do this all the time. We get emails, we get calls. It's usually, help, what do I do? I've been in this really weird situation. There's a ton of time we're like, shoot, we don't know what to do, but here's what we think, and we howl out amongst ourselves. But I tell my patients, look, if you are not happy, get another opinion. One, I'm confident I'm giving you the best one, and they're going to tell you that. But even better, what if I miss something? I'm happy to put my ego in check, and if someone else picked up something that I missed, came up with something better, thank God. I dodged a bullet, patient dodged a bullet, right?
Yeah.
So there is nothing wrong. And I mean, it's easy for us to say this because like the docs in this room, this is what we do, this is what we think about. We get up and think and read about TTP, and it's just easier for us to do it. But if you're not doing this, right? If you're seeing, a hematologist oncologist, they're also dealing with lung cancer, and the patient with myeloma, or the patient with prostate cancer, or the person with the brain tumor who they're sending to the, it's everything all at once. And it's not unreasonable. I would recommend that you seek someone out locally who has expertise in TTP and can work with your doc. We do this all the time. In Colorado, we're the only academic medical center, so we have patients from the western side of Kansas. No, I would defer to my eastern Kansas colleague instead. But from Nebraska, Montana, Wyoming, and they can't drive 8 hours every week to see me. We have to partner up with, hopefully another hem-onc, but usually a primary care doc. And as long, I think that helps them out a lot, that they're not in left field when, oh, that guy, that academic university clown, like he says that this is okay, and they have something to hang their hat on.
Question, is there a way to, you're talking about second opinions, is there a way that you recommend to find that second opinion doctor that's specific to TTP? Like, I know with Lyme disease, there's a site you go to and you fill out an application, they send you a list of, Lyme doctors are like in your area. Is there a way?
Yeah, we'll go look at the USC.
It's got, okay.
So, I don't know how to tell you, could just,
other related doctors?
You guys could just drive right down I-40 and you can have your pick. No, I'm serious. Yeah,
Okay.
Yeah, and you just go to the USTMA website. And of course, there's some people who, we've got lots of patients who are hours and hours away.
Right.
We do have mechanisms. If you're emailing USTMA, we've got questions for this.
Right.
And, many of us are, we like this, we think about this, our passion. We're more than happy to reach out and talk to someone's docs about this.
Okay.
I know you guys, you're in good hands. I'm not, But yeah, if anyone else who wants a second opinion about something, there's no reason that it should not go get it. And on that note, any other questions? Is lunch ready?
They're setting it up right now.
Okay. I think I bored them into submission.
There you go. There you go.
All right. Well, thank you, everyone.
Thank you.